Excuse me, everyone. We now have all of our speakers in conference. Please be aware that each of your lines is in a listen-only mode. At this time, I would like to turn the conference over to Mr. Wayne Millington. Please go ahead, sir.
Good afternoon, good morning to viewers on the West Coast, Alaska, and Hawaii. Welcome to our webinar, Health is a Team Sport, a playbook for engaging men in diabetes prevention and management. My name is Wayne Millington, and I'm a Senior Public Health Advisor in the Division of Diabetes Translation of the Centers for Disease Control and Prevention. I'm responsible for providing strategic direction on public health policy, programs, and practice. I'll be your moderator for today. Throughout the webinar, please feel free to submit questions via the chat box. We will do our best to respond to chat questions during the webinar, and we'll follow up after the event as well. Presenters may also ask you to type answers in the chat box. You will see it at the upper right hand of your screen. If you haven't included your affiliation after your name, please do so by selecting Edit My Info from the top right hand corner of the attendees box. You will then see a pop-up allowing you to edit your information. Making this change will help connect participants and let us know where you're joining from today. Today's objectives are to recognize the challenges men face in preventing type 2 diabetes and or living with diabetes, identify barriers for men participation and retention in type 2 diabetes prevention and management programs, and to identify strategies to increase men participation in type 2 diabetes prevention programs or diabetes self-management education support program services. And now let's get started with today's webinar. We've got a fantastic guest today, Peter Simpson, Dr. George Nani, Aaron Perry, and Darrell Davidson. Before I introduce our first presenter, we want to hear from you. What is the biggest challenge you face in engaging men in type 2 diabetes prevention or management? Please enter your thoughts in the chat box. Thank you for sharing. We hope to learn today about strategies that would help you with some of these concerns and barriers. I would now like to introduce our first presenter. Peter has over 49 years of business experience in medical research and healthcare arena. His client experience includes Johnson & Johnson, Boston Scientific, Medtronic, Pfizer, Roswell Park Cancer Institute, ConAgra, the American Medical Association, the Center for Disease Control and Prevention, and many more companies and organizations. Peter's skills include strategic planning processes, branding issues, market segmentation, and healthcare marketing, and innovative marketing research. In over 2 decades of consulting with the healthcare industry, he has conducted numerous research projects. In particular, he has worked on developing cycle-based methodologies for medical market research. Now I'd like to turn it over to Peter.
Thank you, Wayne, and my greetings to everyone today. Thank you for being here. This is going to be in 2 sections. The first is going to be a look at epidemiological and demographic information, and then we're going to look at psychological information. And as we do those 2 things, we're going to kind of build a picture of risk and issues as it relates to men and men of particular demographic backgrounds. So let's start right away. What is the size of the problem? I think we all are aware there are about 30 million people who are thought to have type 2 diabetes in this country, of whom about a quarter are unaware of the fact. And this adds up to about 12 to 12.2% of the total adult population. In most cases, men and women, when we look at prevalence numbers, are not that different between the two genders, not within statistical significance, as we can see here. So we actually need to build a picture of men and men's other demographic and psychological features, which puts them at a greater risk. We will certainly see that education is a strong marker. And in fact, if we look at this slide, the left-hand panel demonstrates that we have nearly double the incidence amongst people with lower level of education, less than high school, than those people with more than high school. And across a lot of research projects that we've conducted at Experian, we found this to be very consistent. Looking at the middle panel, there isn't a great deal of difference between men and women in terms of diagnosed levels, but there seems to be a higher difference in terms of the estimated undiagnosed amount. And on the right-hand panel, we can see that outside of the white Caucasian and Asian populations, different ethnicities have between 50 and 100% greater level of incidence of type 2 diabetes. And of course, I think, again, we are mostly all aware of this, that in the National Diabetes Prevention Program, only a quarter of those who enter the program or persist in the program are male. And there are probably a lot of different reasons for this. As we build up our picture of men, let's kind of try to think about that. So when it gets to prediabetes, we have to recognize that there are many more people who are not aware of their situation. In fact, of the estimated 84 million people with prediabetes, we think only 10% have an awareness of that. And that awareness is much lower amongst men than women, and we'll start to see some of the reasons why that is. And then finally, in the demographics, these are heat maps from the CDC. They're at the county level. The left-hand one shows the incidence of clinically diagnosed obesity. I should say the prevalence. The center one shows the prevalence of type 2 diabetes. And the right-hand one shows food deserts. And food desert, as we know, is not a person, is not a place. A food desert is a person who lives more than a mile from a grocery store and does not have some form of personal transportation. And it's reasonable to suppose that the prediabetes maps out the same way. So not only are gender, ethnicity, and education risk factors, location and income are risk factors as well. So as we build up this picture, we can see that as well as being male is not a particularly bad thing, but being an older male, being a poorer male, being a male in certain locations, and being a male of color, these are highly cumulative risk factors, as I'm sure other panelists will agree and speak to. This flow map is from my company's prediabetes study from last year. And I'd like to start and just focus at the top middle where it says diagnosed with little explanation. And what we find is that when primary care physicians are advising patients with prediabetes and diabetes, in most cases, and with some honorable exceptions, they make a very poor job of it. The conversation immediately becomes one of obesity. It leaves patients feeling criminalized and victimized, feeling that they are being told, and maybe they are being told, that they lack self-control and self-respect, they can't keep their promises. And so the dotted wavy line shows that a very small number with PCP and other practice staff support find their way to a dietitian, to a program, to be prescribed with metformin, to compliance with these things, leading to a maintenance or a reduction of A1C. And there are certainly quite a lot of cases where people back out of prediabetes in this way, and I can attest to this because I'm one of them. However, most people move to the top right. They get a wake-up call. They get brief levels of motivation. They try different things, usually fail, and they enter into a vicious circle of failure and depression with sometimes tangible impact on their mental health. So as we move forward and see what doctors actually recommend, from the studies that we have conducted, 2/3 of patients who have prediabetes are simply told to lose weight without any specificity to that recommendation. Nearly 40% are given information to take home and read. About a quarter are asked to test their blood sugar, and further research has shown that's where they're at or below their normal or their ideal weight, which of course causes the physician to be clinically much more concerned about them. And a quarter are asked to see a nutritionist, but again with normally no specificity as to which nutritionist to see, and so on down the line. Less than a half say that their physician discusses prediabetes with them on every visit, and a quarter say their physician discusses very rarely. And when we talk to physicians about this, it's clear that they feel unequipped, untrained, that they don't have the time, or even it's not their job to bring about behavioral change, and that's why so many patients fall into this depressive, vicious circle. And we find that, excuse me, diagnosis doesn't drive better behavior. So on this bar chart, on the left of each cluster, we see people with type 2 diabetes. In the middle, with diagnosed prediabetes. On the right, a balanced sample of consumers who have neither, as far as they know. And you'll see that there is a marginal but distinct tendency for those with type 2 diabetes and prediabetes still to favor a high level of carb intake into their diet. And in fact, when you get granular about things like added sugar, you find that actually there's an increasing tendency for that to be the case. So as we think about men and women, men are, from our studies, less likely to go for an annual checkup with their primary, less likely to visit with some illness or concern, less likely to use a walk-in clinic, although certainly they favor walk-in clinics for reasons we'll come to at the end, and they spend less time researching on their physicians. And as we move to the bottom bullet, they have a lower regard for the US healthcare system by quite a large level. The only positive thing we can say is they're more comfortable in taking medications than women are. So they're less concerned about their health, or at least that manifests itself less in proactivity. Women's prediabetes experience too is different. Women are much more likely to report having received a diagnosis of obesity and a diagnosis of anxiety. Women are much more likely to report attendance, as we know, to a prevention program, or in our studies to other forms of help, such as using in-grocery store dietitians. Men are more likely to know the numbers. They're more likely to know their A1C score. Women are more likely to know the directionality of that score, whether it's getting better or worse, or what the significance of that score might be. So this is one of our company heroes, Sir William Osler, the great Canadian teaching physician. He was one of the founders of Johns Hopkins Hospital in Baltimore, and he taught 120 years ago that it's more important to know what kind of patient has the disease than what kind of disease the patient has, and that's where we're going to focus for the rest of my input. But at this point, we're just going to pause and ask you to answer a question. What percentage of individuals with prediabetes say that their physician discusses it with them on every visit? Can you make some input to that? Okay, so I think it's interesting and very meaningful that 50% of you voted for 18%. The number that I showed in my studies was actually 44, but I think it's very characteristic of what you consider the problem to be, and your focus is in the right direction. You're erring in the right direction. So let us move along. So I want to talk about personality. This is our Persona Smart personality-based healthcare engagement model. It's based on a globally validated personality assessment model. And what it tells us is that about 10% of the population on the left-hand side there, the proactives, are people who face up to a diagnosis. They work on a disease. They have internal locus of control. They use their physician as a resource. The next group, about 25%, want to be good patients, but they want to live most of the time as if everything was normal. That's why we call them seeks normality. They will give themselves drug holidays. They will take time off from seeing their doctor or getting their labs. They will be episodically engaged with any disease, and that, of course, includes diabetes. The hopefuls, about 35%, just are fatalistic. They just hope things will turn out okay. They'll rely on the doctor. They'll rely on God. They'll rely on their family. They think of themselves as being normal people. It's just their body is sick. And finally, about 30% are absolute avoiders. They just do not want to deal with this at any notion. So we start to see that the combination of being male, poor, ethnic, and to the right-hand side of this scale, which is essentially one of self-efficacy, that's a very bad place to be. That's accumulated risk factor. And we can use these types through any kind of behavioral model we want. This is the old transserotical model of change. It dates back 50 or 60 years. I think it's still a good one. It shows how people go through a process in their changing their behavior, also with relapses and restarts. And it's very important to know two things when you're designing a program. One is, what kind of person are you dealing with? And the other one is, what stage are they at in their behavioral change process? So let me summarize. These are stereotypes. These are buckets. Right, there are 7.7 billion people on Earth. When we try to squeeze them into 4 buckets, there's a high level of generalization. Do the math, right? So we know these things, and they may not apply to every individual. But when we're looking to engage men on healthcare, we need to know where they stand in terms of their engagement overall and their level of self-efficacy. We need to remember that men look after their cars like women look after their bodies, and women look after their cars like men look after their bodies. And it's very sexist, but my excuse is that a doctor told me that. That men tend to deny conditions and think of obesity and diabetes as being normal, not even an illness necessarily, certainly obesity. And they want to seek convenient solutions. So health hubs, in-store clinics are most popular amongst men between 25 and 50 years old who can park easily, get seen quickly, and probably by a woman who will sympathize with them. So in and out. So we need to think about that and remember that men are going to seek convenience. And this is maybe one of the reasons why they don't want to attend the DPP. They may just actually want something that's much simpler. So that's the summary of what I've had to say, and I'm happy now to hand back to Wayne.
Thank you, Peter. We will now discuss the barriers to engaging men in type 2 diabetes prevention and diabetes management. But before we move forward, I'd just like to recap the first question we had and some of the challenges that we face. And thanks for your input. We have a number of really great insights into some of the challenges we face. We had one talk about how do we access the readiness to change and want to change. We also had one regarding not wanting to ask or upset assistance. Marketing and referrals, how do we deal with that? Also recognizing the problem and willingness to participate. And getting there, how do we get men to join a class that's full of women? So I think that was one of the most interesting ones. But we will get into that a little bit later on. I would now like to introduce Dr. Sala Georgiani. Dr. Georgiani received his bachelor's and doctor's of pharmacy degree from Columbia University. He has extensive experience in all aspects of practice of pharmacy and has held faculty appointments at Columbia and Delmont Universities. Dr. Georgiani is a licensed pharmacist in his home state of New York, and in Florida he holds both general and consultant pharmacist license. Dr. Georgiani's professional career includes 27 years at Pfizer headquarters in New York City, where he held various responsibilities include the medical, regulatory affairs, corporate planning, and marketing groups. He currently is senior scientific advisor to the National Men Health Network and co-founder and chair emerit of the American Public Health Association section on men's health. He is author of over 70 publications and scientific presentations and is an editor reviewer for the American Journal of Men's Health. He is recognized expert on effects of culture, advertising, socialization, and male perceptions of health and wellness, and is a frequent speaker on this topic. He practiced clinical pharmacy with emphasis on medication adherence as part of family medicine practice owned by his physician's son in Florida. I will now turn it over to Dr. George Nani.
Thank you for that lovely introduction. I appreciate it. I found some of the questions or issues that people face very important. Building rapport, getting men to join groups and go to get care, and getting physicians to refer men. So hopefully the next couple of minutes I'll spend giving you some of the background and some of the perspectives that I and my colleagues at Men's Health Network feel are at play here. A little bit about the Men's Health Network. We're celebrating about 25 years. I've been working with them for about 15 years, and Men's Health Network is the largest and oldest health advocacy organization that covers the spectrum of healthcare issues across the lifespan for boys and men and across all sorts of medical conditions as well as wellness. We, like Men's Health Network, likes to say their motto is to help men and boys become healthier where they live, work, play, and pray. Part of our expertise, and that's, I guess, why we were asked to present a little bit here, is engage men in health and wellness. We learned how to do that. We've been very successful in developing programs, projects, practices, and helping other organizations engage boys and men in a meaningful way. So in the next, that's a little bit about the Men's Health Network. In the next slide, we'll talk about men and their health. One of the areas that I find very interesting, and I think it's a little bit of a byproduct from my work at Pfizer, is to view how the media shapes the opinions of boys and men and of young women, girls and women, about health and health care. At the same time as we look at how social structures and media can affect it, we can't ignore a couple of million years of evolutionary history, because men do and will always look at themselves as hunter-gatherers, not so much as caregivers unless they go into a caregiving profession, but then when they come out in their home, they still sort of take on the role of hunter-gatherers. So we have to temper our view of what is realistic for men and how we provide information and incentivize men and develop that rapport with men there. When you look at some of the factors that men tell us in general, not just for diabetes, why they don't want to seek health care, it makes them look weak, whether that's in the work environment or social clubs, and it makes them look weak, and it doesn't advance any of their careers. Men are acculturated from a very young age to disregard wellness. You can see some of the phrases that are particularly prevalent, and that I think also helps shape the view of boys, men, and young girls when they hear these being thrown at young boys. In the next slide, I present a little bit of the information on male perspectives in the media. Males are generally viewed in an action role. Men who care about health are often, unfortunately, portrayed as uncool. Men and boys do not read about health as often as women do, and much of the advertising that's directed to the American public is characterized in context of women rather than men. And this is a little study that I and some of my associates at Belmont University in Nashville did that looked at the health advertising, print advertising in magazines, and you can see the dominant themes, whether they be graphically, verbally, or otherwise, were geared towards towards women, and that was my generalized experience at Pfizer as well. At the time that most advertising executives within the corporation, and I was in a medical group much of my time there, viewed the drivers of healthcare decision-making as women, so they geared much of what we did towards women. So when you're looking for reasons why maybe it's a little bit difficult to get through to the guys or to try and understand, particularly women providers or even male healthcare providers who consider health a very important part and almost genderless in the healthcare provider market. It's a little difficult for us to understand when we see some of these issues and how men are barraged with these anti-wellness messages. In the next slide, we talk a little bit about, there we go, the healthcare system. Well, it's not friendly to men. That's something that Men's Health Network and I try to correct. I know in my son's practice we try to be a little more male-friendly and try to adapt what we do to the men. It's not enough to really take a generalized program that was worked well with women and sort of make it blue and turn it on to the guys. You've got to, and we've learned that at Men's Health Network over years of experience in crafting messaging, programming, outreach efforts, and even policy. It's got to be done for the guys at the outset. It's a really important point for all of you who are looking to bring men into your programs. Men like their messages a little bit differently. You can't help the fact that men, that healthcare providers are gender-based, acculturated themselves. So while they tend to look at healthcare very differently and wellness very differently than the general population, we all are subject to evolution and just social context. One of the areas Men's Health Network looks from a policy perspective to change is few resources for men and boys out there. There's no Federal Office of Men's Health. There are very few state offices of Men's Health. Very few are funded. When you look, and I've done a series of surveys over, along with some colleagues at Men's Health Network and others, that looked at state public health departments' ability or programs to reach men and boys. There's not an awful lot out there. There are no men's hospitals, and unfortunately, there's not a funding source for men-focused health research, and Men's Health Network is trying to change that vigorously. In the next, one other point on this slide before we move back, one slide back, please. We've done studies, I've published with Dimitris Porsche, who's the Dean of the Medical School at LSU, a survey of programs that offer men's health specific curricula. There are very, very few. In fact, one of our advisors has told us that on the family practice boards, there are two questions that are oriented to men's health specifically, and both of them have to deal with, guess what, prostate cancer, rather than overall male-directed health issues. So here again, the training, we think that there is a lapse in training and there is no defined specialty for men's health per se. And the next slide, there we go. I won't reiterate the information that Peter so aptly presented before, but just to reinforce that the men really don't engage the healthcare system as frequently as women do. They can't identify a regular physician. And very importantly, that 1, 2, 3, 4, fifth point down there, men wait much longer to see physicians when symptoms occur. And that often complicates treatment. And then there are several studies, I'm sure you could all look them up and get lots of staggering strategic statistics, which show that men do not come to diabetes care until much later on than do women. And I think that's also reflected and embedded in some of the information that was previously presented to you in the National Diabetes Study. So I think the issue is the underdiagnosed or the untreated guy. Next slide. The stigma of disease is a very important and difficult issue for men. I talked a little bit about up front how men who have medical conditions or have to go into the men's room to take an insulin shot or who can't engage in a full diet, if they're a hard-charging business executive in any major corporation in the world or even smaller corporation, they really have a very difficult time dealing with some of the restrictions that they have because of the stigma of looking weak. And I think that is a very difficult sociocultural context for healthcare providers to overcome. We see this in women in some conditions, but in conditions such as diabetes, metabolic conditions, I don't think it is as prevalent as it is in many of the men. Now, I don't know that there's been a study looking at career women to see if this issue of stigma is as prominent in boys and men, but that certainly would be an intriguing kind of study for someone to do. Next one. The uncomfortable truth about boys and men and health is that, in the next slide, we met the enemy and it's the guys. When I speak to groups out there, I often talk about the fact that men really need to take a page out of the Women's Health Playbook from the 1960s and 70s, and they have to make their health care their issue. And the next slide, get a couple of suggestions. Oh, yes, I'm sorry, this got plopped in there. It probably looks a little bit out of order. My mistake. Peter spoke a little bit about how there's some there are non-differences in men and women in diabetes. But when you look at the bottom line, the adjusted death rate for diabetes, all types, from CDC data, is significantly higher in men than in women, with a ratio of 1.54 men favoring women. So whatever is going on when the cause of death is attributable, the age-adjusted death rate to men for diabetes is much higher. And that, I think, reflects on the number of men who come into treatment and then leave it or never come in at all. Next slide. What can you do? There are lots of opportunities to engage men and boys in healthcare practices. I think we had a male physician, boys or men's health specialty, it would be a lot easier. We in Men's Health Network, and I in particular, feel that family physicians are uniquely positioned to be able to provide that kind of information and that kind of life across the lifespan and across all medical conditions, health for boys and men, but yet they're not recognized as, and they don't have many men doing, many physicians doing men's health practice. Using sports physicals is one technique that family physicians who focus on guys use to get boys engaged in healthcare early on. Multi-system screening programs we all talk about treating all of the conditions at one point and not just focusing on one thing at a time. So guys like that sort of position. Once you get them engaged in their health, you've got to try and help them fix everything. Careful approach to the discussion of prediabetes. There was an interesting discussion before where I think Peter used the words that when men get a diagnosis of prediabetes or some other conditions, they feel criminalized. I think they are stigmatized, but they can't control themselves. Guys hate being out of control. So one caution to all of the clinicians out there, and we try this in my practice, is carefully approach the way you talk about prediabetes. So you don't want to drive the guys away. You want to engage them in becoming engaged in their care, not scaring them or making them, trying to minimize the stigma issue. Use educational tools. I covered this before. Designed for boys and men. You just can't take something that's worked for women and just, put a little different picture on it. You've got to think about how to approach boys and men from the outset. Boys and men like a little bit of humor with their health care, and they really like to engage in their health care. As guys, and many of the people, I think our next speaker will talk a little bit about that, like to have their health care just guy sections. Try guy sessions rather than sessions for women and men, just like very popular women's only exercise facilities. I think we can see some very popular programs just for men. And the last slide, the most influential tool of all, is to try and make covenants with patients. We all know the strong links between diabetes and other metabolic conditions with erectile dysfunction, low testosterone levels, and other conditions that the guys traditionally care a lot about. So if you can try to make a linkage between treating what's important to the guy, and certainly ED is important to many men, particularly over their 50s, I think you'll have a lot more success in treating the guys. And that's it. So, yeah, we'll just leave that slide up there if any questions come up. I think I covered all the material there. Okay, my time's up.
Great. Thank you, Dr. George Nani. Before I introduce our last presenters, we have another opportunity for you to share your input. What is the top marketing strategy you have found to be helpful to reach men about programs and services for diabetes? Thank you. So one interesting one up there was the advertisement of food. So as we move forward, I would now like to introduce our last two presenters. Aaron is the president of Rebalance Life Wellness Association, whose goal is ensuring that African American males live in underrepresented communities, live fuller and healthier lives. Aaron is a former police officer and a current member of Dade County Gang Response Intervention Team. Aaron was diagnosed with type 1 diabetes at age 29, and since then has become the leading health advocate focusing on preventing chronic health conditions in black men and boys. At age 44, Aaron became the world's first insulin-dependent person with type 1 diabetes to ever complete the Ironman triathlon. In 2016, Aaron opened the nation's first men's health and education center located inside the city of Madison's largest black barber shop, and in 2018, he was selected as one of Time Magazine's 50 most influential people in healthcare, thinking outside the hospital. Presenting with Aaron will be Darrell Davidson. Darrell is the men's health manager at the City of Milwaukee Health Department. He oversees programs, preventive education, and outreach activities related to teens, male, and men. He achieved one of his public health career goals when he helped establish a men's health center as the entry point to address various issues that affect male health. He valued client-centered approaches when solving problems related to communicable disease and family and community health. Darrell attributes his peers' work in sexual health, HIV education, adolescent health, and domestic violence prevention as the glue that allows success in his present activities. He's a member of the National Men's Health Network and the Wisconsin Public Health Association, and is a founding member of the American Public Health Association Men's Health Caucus. He's also a program co-chair with the Milwaukee Fatherhood Initiative Annual Fatherhood Summit. Now I'll turn things over to Aaron and Darrell.
Thank you, Wayne, and thank you to everybody that's participating. Today, Darrell and I will share our experiences with successfully engaging men in diabetes care. For me, at age 29, actually, I was diagnosed with type 2 diabetes, and I lived with that diagnosis for 2 years. Definitely was not getting better. My health care and what was being prescribed was not working. However, at age 31, I was properly diagnosed with type 1 diabetes, and I share that with you because I had to become an advocate for my own health. And when you receive pushback from patients, please, keep in mind that sometimes what is being prescribed is not working, and so that pushback is from the patient because we know that something is not right. I became a health advocate representing the diabetes community throughout the state of Wisconsin and narrowed my focus to black boys and men specific to Madison, Wisconsin, Dane County. This was the first and most important thing that I did. I was to engage with the Madison, Dane County Public Health Department to commission a report titled The Social and Health Conditions of Black Males. The 2018 census places Dane County population at about 542,000 residents. However, what was helpful to us is to understand that black males in Dane County accounted for 6% of the male population. There's 15,600 of us. And I share that because that, again, knowing what you're working with in terms of the number of people that are in the community was very important. So education, income, and where we live, if you can go to the next slide, where we live are as important to our health as our behavior, health care, and genetics combined. In Wisconsin, black males' life expectancy is 7 years shorter than white males. In addition, African Americans in Dane County suffer higher rates of cancer, obesity, and diabetes as compared to whites. Helping us to navigate barriers, if you want to go to the next slide, helping us navigate barriers such as fear, shame, lack of trust. We also engage with community partners here in Madison, Wisconsin, SSM Health and the Wisconsin Partnership Program, which is part of the University of Wisconsin School of Medicine and Public Health. As health advocates, we all combine together to understand the data from community partners, and then we coordinated a series of listening sessions with black men and boys from a location that they're comfortable, that they trust, and this led us to the city of Madison's largest black barber shop. If you want to go to the next slide. More than 1,700 black men expressed a very strong desire to us to be educated about their health outside of the healthcare facilities. And we listened to that, very important, 1,700. So in 2016, we opened the nation's first men's health and education center inside of Madison's largest black barber shop. And in this location, we are able to do a lot of preventative health screening. We have also pinpointed a significant number of men living with diabetes in our community. And this is by understanding what the zip codes are in our area. And more importantly, just listening to our men. We are 100% clientele-centered. That is the approach that we take. So the majority of what we do is about listening to what our men state they need. But in this Men's Health and Education Center, we can do daily blood pressure screening, diabetes testing, oral health care, free oral health care, flu shots. We do insurance enrollment, and we recently added a mental health counselor as well as a substance abuse counselor. We do yoga classes for men, adult men, and we also do yoga classes for middle school boys. Diabetes patients with depression have poor adherence to self-management behaviors compared to those without depression. And so these are some of the areas that we are going to continue to push forward in terms of engaging and breaking through the many barriers that we see that are present with our men's health. Go to the next slide, please.
In Milwaukee, Wisconsin, we have what's called our Men's Health Center, which is located in 3 different parts of the city, and each one of them is a one-stop shop for Milwaukee men. It has an availability of health education in groups, health education as for individual sessions. We're also doing health insurance enrollments, and we're tailoring the services to meet their needs based on assessments. One of the needs that came out of the assessments was the need for getting trained educators in the Healthy Living with Diabetes curriculum. So the Healthy Living with Diabetes curriculum is a model self-management program developed by Stanford University, and it was designed for individuals with type 1 diabetes, type 2, as well as prediabetes, or for those who live with or care for individuals with diabetes. We're doing this activity in partnership with the Wisconsin Institute for Healthy Aging and the Milwaukee Housing Authority. These classes are 2.5 hours once a week for 6 weeks with a 7th session. And keeping the philosophy of what the Men's Health Network has, we're trying to reach men where they live, work, play, and pray. So we're scheduling the sessions around lunch. We're scheduling the sessions around dinner whenever the men are available. We've set it up with the housing authority so that the men who live in those facilities can come downstairs and listen to us. We have pre-sessions in case they don't, their schedules don't match our sessions, and we also have makeup sessions for them. The other activity that we're very proud of is sustained eye screening using mobile teleophthalmology. And the Men's Health Program here in Milwaukee is a team member of the Tele-Eye Health Collaborative, which includes the Medical College of Wisconsin, our community organization titled the United Community Center on the south side of Milwaukee, our City of Milwaukee Well Women's Program, Carroll University, and Marquette University. And so all of these project partners are available to assist each other in implementing a new sustainable eye disease screening system using a mobile unit. It's a device that can detect early signs of diabetes and pre-diabetes. It's a non-invasive camera. It's just like going to the ophthalmologist's office and they take a picture. That picture is sent to the ophthalmologist who is working on our team, and then there is a diagnosis made mobily based on what the image is saying. And when we receive the image again, we're able to let the individual know if they need to come back for another recommendation. We have the ophthalmologists who are at the Medical College of Wisconsin and a local hospital who assist us with any type of information that might be of great concern to the people who participate in this program. Now, our Diabetic Retinopathy Project has provided over 800 screenings and identified early stages of diabetes using this as an entry point to address other preventive health concerns, because just as we can see what type of influence diabetes has had on the retina or any of the other elements in the eye, it can also discern if a person has high cholesterol. It can tell if someone has other types of damages, and this can be done at an early level. So we have a men's health nurse, men's health educator, and they're trained to do the screening as well as do the A1C screening. The A1C is a blood test that reflects your average blood glucose levels over the past 3 months. They are available at our men's health centers, and we make a conscious effort to identify men in every community, but we have a special focus on our African American males because it is one of the leading causes of blindness, heart disease. Diabetes is one of the leading causes of blindness, heart disease, and stroke in our community. So we are trying to close the gaps required by meeting people where they are and by working through relationships that they've already established. So those could be social relationships, church relationships, or even their family relationships. So the healthcare disparities, they exist. Racial health disparities, educational levels make a difference, employment, housing, income levels, access to community resources. We see a variety of those healthcare disparities coming from numerous social determinants of health, and so we're trying to address them in as many ways as we can. And even when we're doing publicity around our events and outreach, we always make sure to have male images, or at the very least, in the locations where we have these events, we try to bring images of positive male health and men in activities related to health so that people can make that the standard.
And to piggyback off of what Darrell is indicating, closing the gap requires meeting people where they are and establishing relationships. And by having our Men's Health and Education Center located in the Barber Shop, we've engaged our barbers. We've trained them on how to do blood pressure screenings. we've brought in healthcare professionals and physicians from the community that help train them on certain signs to look for in terms of lines on the back of the neck, zeroing in when the clientele talks about certain concerns that they have. And so a lot of these things have been very effective as we focus on engaging our men, particularly from a place that they trust, respect, and feel welcome. The other activities that we do with our Black Men Run group, we build social cohesion, which we find is very important in our area. Right now we do daily runs. We do runs on the weekend where we have about 81 men that have successfully joined our running group. Of that 81 men, 27 are living their daily lives with type 1 and type 2 diabetes. So we often have those discussions as we're running. But we focus on the chronic health conditions, and also what we're learning in this process is that not only are men dealing with the diabetes, type 1, type 2 diabetes, but they are also dealing with a significant number of other chronic health conditions. And so that's why we know that building that social cohesion and encouraging our men to talk about their health challenges really makes a significant difference. But we've seen some significant success with our Men's Health and Education Center, as well as our community activities that we do with our African American men and boys in this area. Thank you.
Great, thank you. You shared some great information here today. Thank you all of our presenters. I'd now like to invite all of our presenters back now that we ask if there's anything to add or to answer any of your questions. Please submit questions using the chat box on the right side of your screen. Great, look like we have some questions. For Dr. George Nani or anyone who would like to share, we have a question. Are there any programs and practices that employ CHW, community health workers, to work on diabetes and other men's health issues?
That's a fabulous question. I think you just saw a great example of that from the two wonderful gentlemen in Milwaukee. Men's Health Network has actually developed a community health educators program specifically designed for men. It goes into some of the sociocultural presentation styles, ways to do as they've done in Milwaukee, create these programs in the context that's comfortable for the guys. So yeah, that is a program. I don't know of too many places where it's being done, quite frankly. We've done a few of these programs. They've been very well received where it's been done, and we are always willing to do more. And then maybe Darrell or your colleague can have a comment too about that.
Yes, as a matter of fact, in Milwaukee, we are using community health workers specifically with men's health for the areas of heart disease prevention and education, as well as for our smoking cessation project. We have classes here at our Area Health Education Center, so in the fall of 2019, they're going to be offering them from October to November. So if anyone is in the Midwest, I'd be happy to give that information to them. And we have two community health workers who are working with us on projects right now. We will be moving them into diabetes in the near future.
Great. We have another question. Do you know anyone currently that is delivering the DPP successfully to men? And this is for anyone who may want to take a shot at this.
Sorry, I can't comment on that, Dr. Trogiani. Sorry.
Okay, we will get back with you through our website on this particular question. We have another one. How responsive are men towards a female educator versus a male educator, do they respond differently? How do men respond to female versus men?
Dr. Strickland, I'll take a first swipe at that. There have been some studies done on male to female communications in healthcare. Generally, they're equivocal and they don't show a huge difference. I will say, though, that and men are not a homogeneous group. I mean, it's very different. And I think a lot of it is the approach that's taken. We have found in some work that I was engaged in at Pfizer that women providers are able to develop a better rapport with men in some conditions, particularly in sexual health conditions, and it usually is a middle-aged female provider as opposed to a younger female provider. But I think that the context in which the information is delivered for most men is much more important than the gender identity or gender of the person delivering that information. We're interested to hear if others have to comment on that.
So, go ahead.
Yeah, what I can add is here in the Barber Shop with our Men's Health and Education Center, we've partnered with the Edgewood College Nursing program, and so we have about 8 female nursing interns that come in. We also have 3 UW medical students, females, that come in and do a rotating schedule. What we've found is that the environment that these men are in plays a critical part of that, because they are in a location, the barber shop, where they trust and respect. We do not see any concerns, and we've been doing this for 3 years, and yet to observe any concerns having our female students helping us out here. So I think more of it has to do with the environment and the location of where your programming is at.
That's a great point. Yes, absolutely.
So the example that I was going to give, the lead educators in Milwaukee are all male, and for the most part they're African-American male because we're primarily working with African-American audiences. But there will be points at in most of our long-term sessions when we will have a female instructor or subject matter expert who will come in. So independently, we haven't really seen what type of effect they have on the audience, but I can say that they have been a wonderful addition to the information that we've shared with the audiences so far, and we're not noticing any type of negative reaction when we're getting our surveys back. I also want to address what came up before, which was related to some of the outcomes that we've experienced here. But we have seen improvements in A1C levels. We've seen individuals improve self-identified health outcomes related to diabetes. We noticed that there's reduced distress around talking about the subject matter, and there's also a higher level of compliance after they've completed the Healthy Living with Diabetes workshops.
We have another question for Dr. Georgiani, I believe. Do you have more on types of education that works best on each of the 4 behavioral levels?
Hi. I don't have anything specific. I do think I will totally agree that getting men actively involved in activities in places where they feel comfortable with are a key to success in any medical condition, getting them engaged. So I'm not an expert on behavioral levels. I'd leave that pretty much for Peter to answer. I'd be interested in the answer myself.
I think that, as indicated in my remarks, that what's important is to understand that there are different personality types with different levels of self-efficacy. So it's important to think about men and boys. It's important to think about African-American men and boys. But within those groups, we're going to find different levels of ability to deal with things based on those individual personalities. So but the only contribution I can make to this is to suggest that where possible, we build in some very basic psychoprofiling into programs so that programs can be modified and interactions can be modified accordingly. It's not actually a difficult thing to do.
That's a great kind of question for folks at PCORI and MHN. You know, we do work a lot with PCORI, and that might be a fertile area for research for us or anyone.
Another question we have in the box is, what is the best way to address EDS?
EDS, I'm sorry, that acronym is for, I always tend to think of ED as erectile dysfunction. EDS?
Yes, I believe it's erectile dysfunction.
Oh, okay. Straight on. I think one of the conditions that men are always looking for a comfortable place to talk about the ED is a practitioner who asks, are you having any problems of this kind? Are you having erectile dysfunction? Or sometimes men with diabetes experience erectile dysfunction. So we had done a series of vignettes to help clinicians engage in that discussion in a 3-minute time period, which is usually the time that they feel comfortable dedicating to that condition. But in general, men with that condition like to approach it head on, and I am very direct with them about it. And I think it's, again, studies we had done at Pfizer show that women inquiring also, they get good, straight, and direct responses. It is a trigger point for men to change their behavior. And I think that is, something just to get yourself comfortable with asking that kind of a question. Practice with your colleagues, asking, hey, are you noticing any erectile dysfunction? Sometimes it's a little uncomfortable for clinicians to do that. We're just not generally trained that way. But I do think it's something you can address.
And I would add, this is Peter Simpson, that studies that we've done in this area for pharmaceutical companies, that where a patient doesn't bring the issue up in the middle of a meeting or during an appointment, it becomes an oh, by the way complaint. So the physician has put the pad in his pocket, has folded up his iPad, has got his hand on the handle of the door, is ready to leave. Oh, by the way, doc, I'm having a problem. And what happens then is almost inevitably a sample of Viagra is given. There's no actual discussion about the sexual experience that the man might want to have. And in distinguishing between Viagra and Cialis in particular, it's important to understand the pattern of sexual activity that the man is having difficulty with, is desiring, and to get the right medication. And very often that doesn't happen for just that reason.
That's such a great point, and that was our experience as well. It was the second when Viagra was launched, physicians couldn't wait to get out of the office quickly, some of them anyway, because they weren't used to having that conversation. And what you say is so important, because it's not just the right medication, but setting the appropriate expectations for the patient and his partner about how to re-engage in sexual activity if they've lost intimacy for several years. You may not be able to just, if you pardon the pun, jump right into it. You've got to sort of re-engage over a period of time. So that's another topic we could discuss another time, but I think it goes to the point of educating the patient has to come with all of these disease conditions.
Does leveraging technology, example phone apps, to engage men in diabetes prevention or diabetes management program work?
This is Peter. I'd like to kick that one off if I may. According to IMS, there are over 200,000 English language, actually around 250,000 English language health and wellness apps available in the US, and about half are intended for consumers and half for professionals. 12% of them account for 90% of the downloads, and the average use time is between 3 and 5 weeks. And we done a lot of testing for pharma and device companies and for health plans and hospital groups of this kind of thing. And one of the things that we find is that people don't want and won't use an app that deals with just one aspect of a condition. So they don't want an app that helps them measure their carbs or their calorie intake or their sugar intake, and another one that helps them manage their insulin, or another one that reminds them to take their metformin, or whatever it might be. There's a tremendous demand for convenient apps that not only would deal with most aspects of one condition, but actually will cover their comorbidities as well. And there are some commercial companies out there working on trying to develop that kind of modular software, which we believe will be very much more successful than single-use apps today.
And I would tend to agree with that as well. As I mentioned through the presentation, try to integrate care across all disease conditions. My view is that the issue on telehealth is sort of the assessment of the outcomes for telehealth. The jury's still out. It's a pretty new technology. I don't think it's just apps alone. I think the extension of that are telehealth programs, telephonic chronic care management programs, which we do in my son's practice, home health care visits, which also we do in our son's practice. So I think that, there are lots of other modalities to reach out to patients outside the traditional office, the kinds of programs that are being done in Milwaukee. Those are all things where there's a huge need for outcomes work on both men and women to see whether these things work or not. But in telehealth in general, I think there's a bright future, but there are a lot of things, particularly reimbursement, that have to be addressed before we really can reach its potential.
And in order to at least address the cultural shift, what we're starting to do is ask questions related to what type of technology that a person might be familiar with or that they might be comfortable using in during the assessment practice. So during their initial visit, we're making it a part of our initial questions. And if they are using a patient-generated app, we'd like to at least have an idea of what type of data is coming from it and how often they're using it. We're in the very early stages. We did something like this related to another chronic illness about 2 years ago. So we're just creating a version of it that's going to be related to its use with the condition of diabetes.
Yeah, one of the things we're seeing here is that we're seeing more men enrolling through online, and I think that's a very good sign. So the technology is there for our use, and I think as long as we could embrace it and help it work for us, I think we're going to see more men using technology in the future. I have another question. Can you provide an example of how you address the stigma associated with diabetes?
Well, I can take that. I've been living with diabetes for most of my half of my life, and what I found is when we're in social settings, I start to talk about it. And believe it or not, once I start sharing, it's like I give permission for other men to start talking about it. We have found that men in our community have been living with diabetes I've known for well over 20 years and never knew that they had diabetes until I started to talk about it. And then they just disclosed. So just being comfortable, having people living with the condition, involve them in that conversation. I found that that's been very effective.
For us, it is a part of the Healthy Living with Diabetes curriculum, and the characteristics of the stigma do include people having negative feelings or blaming themselves because of how other people uncharacteristically may perceive them, or issues around control. So we let them know that they have not only the ability to manage their own health through self-management as well as an active lifestyle, but we also let them know that this is not an environment where they're supposed to blame themselves. We create buddy systems, and we have other activities where they can talk out some of the things that are bothering them the most related to living with the condition and what are the most challenging things And we even have them set goals, and they identify how likely they are to either maintain or to exceed that goal that they've already predicted. And then we give them a time limit, basically by this next week or in the next few days, where will you be with your goal? So that's been really encouraging, and we've been able to see some improvements in how people feel about themselves related to controlling some of the things that are going on in their lives.
Destigmatizing a medical condition, whether it's anxiety, depression, sleep deprivation, diabetes, even for some guys, hypertension can be misperceived. Ironically, now, I mean, we did it with ED by making it a medical condition. You know, it's not something for many men that they have intentionally done. It's not a sign of weakness. So I think the approach always has to be one of gentle coaching and counseling. You have to build that rapport with the patient so that they can tell you why, in their experience, they feel it's stigmatizing. It's probably going to be different for the young athlete, a college athlete, or a high school kid. I think it's going to be very different for a business executive versus a retired gentleman. So I think what folks, clinicians need to do, which is very difficult in this reimbursement environment, is spend time talking with the patient. Now, diabetes educators, I think that they are extremely well suited to doing that. I worked on a program between the American Pharmacists Association and the Diabetes Educators Association, American Association of Diabetes Educators, to help pharmacists counsel their patients on this. So I think it's the dialogue, and it's not an instant fix. You just don't throw some glucotrol tablets at them or insulin with an injection and not talk with them. You have to help them understand that this is manageable, and we give guys the notion that they can manage it, they can lick it. That empowers them. So giving them that sense, and that takes time and a lot of discussion.
Yeah. Great. Another question that popped up was, do you use incentives in your program? It's an incentive that will attract male population and would increase the likelihood of enrolling in a diabetes education program.
I have a little bit of experience with incentives because Pfizer, we did work with the ADA to create some diabetes incentive programs where people would accumulate points and then, cash them in for premiums and things like that. They work for a while, but not for a condition like diabetes. I think you have a secondary issue. How long can the incentives last? So unless you're changing the patient's, the guy's fundamental view of the condition, and then the fundamental view that this is a lifelong thing they have to deal with, giving short incentives, which can only keep up for a finite period of time, I think, really, may not be creating the long-lasting result for diabetes self-care or own self-care. I think better is to work on them in the environment as we saw in the Milwaukee programs, and we've seen some fantastic programs in California as well, where the men are engaged with groups. I think that the incentive is a sense of self-empowerment. That's a lifelong kind of incentive you can build in, and the incentive is I'm healthier and better, I'm going to live better for my family.
So
go ahead.
I was just saying, in Milwaukee, we are not using what we traditionally would use with other conditions. We've had incentives like gift cards and things of that nature, but with this one, we have healthy eating, so we're bringing in food, and we're showing people how to cook. We're showing people how to create a list of healthy fruits and vegetables and proteins to shop for. And we did receive money from a grant through the Milwaukee County Department of Aging, but the incentives have not been the traditional type. It's primarily been related to grocery shopping and food and exercise, but nothing that we've directly given to any of the people who are in the program.
Health plans have extensively tried all kinds of motivational tricks, from reducing premiums to paying for vegetables to giving gym subscriptions. And I think the general conclusion is that you can incent somebody to join a program, but you can't incent them to stay in it successfully. That the program has to do more than give information. Beyond information, you have to give inspiration and aspiration. And maybe that's part of the issue with classes, is every teacher, every leader of a class aspirational and inspirational, because the information by itself and incentive by itself just won't hold most people in.
One of the beautiful things about the programs I was describing in Milwaukee is that they are social programs where men learn how to talk about their health conditions in a comfortable environment. You look at, we often tease in Men's Health Network that women will gather around the water cooler, if you will, and talk about their health issues, and no one thinks too much of it. It's what they do. They have a social network. It's socially acceptable to talk about things that are troubling them, physically or emotionally troubling them. Men are acculturated not to do that. So one of the beautiful things that I see in the programs that are in barber shops and social networks and runs and clubs and groups is that it teaches also that men can talk with peers in a comfortable, safe environment about their health conditions, just like the gals do. And that, I think, is incentive plenty. I can finally talk to somebody about what's really bothering me. And I think that's huge incentive for guys.
One of the activities that we've done, we host a father-son night out event. It's an incentive-based activity, but we invite fathers to bring their sons. We typically host the event at the movie theater where we pay for the movie. We have dinner together. And then one of the activities with this is we brought in a diabetes educator that talks about diabetes. And therefore you start to see these conversations that these fathers are having with their sons and involving them in it. And so it's another way of doing kind of an incentive-based activity. And then from that, we actually developed a committee of fathers that wanted to continue to have those conversations long after the activity ended. So it's an incentive-based, but we've seen a lot of progress with that.
Can we incorporate more messaging and programming around men's preference for action roles and their self-perception as hunters and gatherers into our diabetes prevention and management program?
Sure. I think that you can be very creative. One of the great folks we work with that we know has very successful programs out in Oklahoma, and there's another question about bringing family and friends and stuff. They do a prostate screenings, prostate and pancakes, runs. That is, something, it's not just exclusively for the guys, but certainly a guy-oriented run program I think works well. Anything you can do in an area, baseball programs, Men's Health Network has worked with minor league and major league baseball for programs with some football groups. It's difficult, though, for organizations to fund programs for men. I will say that. So if you can find a champion within your sports network, your local community network, who wants to engage with the guys, that's great. One of the best things you can do is look to where men gravitate. And it's not always sports, but it could be a celebrity chef in your area, or the best chef in your area. Do programs such as fine cooking programs. So there are lots of ways to engage guys in a social way that they find acceptable. And again, go back to the very important point that men are not homogeneous. So not everybody relates to a sports figure, so look for other things that guys relate to in your community. Not everybody relates to mechanical things. It could be an arts group. So there are lots of ways to find the interests of men, as diverse as they are, and then tag health messages or health programs around them.
Great. Do any of our presenters have anything additional to add?
I will add that at the end of our sessions, we will have a graduation. We give out certificates, and that's the time when perhaps partners, families, and friends can attend the final session. The final session is also used as a method to recruit people to future classes.
If I can share a quick story. Back when I was in high school and applying for colleges, there was a time in our community where every kid in the community that filled out a college application, the entire community gathered together and walked with that kid to the mailbox to mail that college application. What we're trying to do is emulate those old things that we used to do when we were kids. We're trying to bring them back and utilizing places like the Barber Shop and the movie theaters to engage people and to build that community again. And so that's what we are attempting to do with our organization, and our community partners have been phenomenal with supporting these out-of-the-box thinking activities.
That's great. That's really, truly, really bringing the community in to support these types of activities. Again, I want to thank everyone in the audience for some great questions today. If you have additional questions, please send them to the Division of Diabetes Translation mailbox, noted here on your screen. We'll follow up with you after our. Be sure to get your continuing education credits. Instructions are listed here and will be emailed to you. As a reminder, a recording of this webinar and the slides will be shared in the near future. Again, thank you for joining us today, and take care.